Talk about evaluation of fitness to dive. Now we talked about injuries. One of the things you probably remember when you did your open water certification was filling out the medical form.
Stand up.
Yeah, it's actually easier for me to see my slides.
Oh, okay.
Yeah, if that's okay, we got to stop it.
For me, it's easier for me to see the screen.
Yeah. All right. So, and I actually want to acknowledge and thank Dr. Simon Mitchell, who's like one of the world's leaders in hyperbaric medicine. He actually gave me some of these slides, so I appreciate it.
So,
Thank you, Doc.
I'm scared about your slides.
Why?
Because I seen the last time you gave a presentation.
There's no gross pictures.
Okay.
And one of the things I actually originally gave this to my medical staff in Goshen, Indiana, and so this is actually targeted primarily for a medical audience that doesn't necessarily have diving experience. So if I say anything medical that you don't understand, just feel free to ask. I'm going to try to switch around to a diving audience that is not a medical audience. And I'm actually giving this talk again at a dive symposium in Cayman. So that'll be a combination of a diving and a medical audience. So we'll have all the combinations here. So as I pointed out to my colleagues who saw us, yes, people do actually dive around here. And recreationally, people dive in central Indiana, in Stone Lake, Fiddler Pond, which is in Goshen, the quarry there, Lake Michigan, as well as the local swimming pools for dive training. There's also occupational diving, particularly public safety diving. Even in the middle of Indiana, the fire and police department have a dive unit. We actually had a presentation here from the Chicago Dive Unit, which is really a spectacular organization that CFD has, and they have a major dive team here. I put in some pictures as well, just to kind of keep things interesting. So this is a picture that I took in Lake Michigan on Nicole's Wreck.
Yeah.
That's actually the wheel. For those of you who don't know, Nicole's Wreck was discovered by Double Action Dive Charters when they were actually en route from the Straits of Mackinac Wreck to the Rotarian, and they were watching on the sonar, and all of a sudden they saw a blip, so they marked the spot, and it was Nicole, was one of the dive masters who went down there and discovered that all of a sudden there's this wreck, and as far as I know, it still hasn't been identified yet.
Not 100%. There's theories, but
Yeah.
you should.
And then up in Milwaukee, this is actually, anyone know which one this is?
Northerner.
Yeah. So that's actually me on the left there. But that was actually a CSM charter that we did. The other thing too is in Indiana in France Park, there's a lake there where there are paddlefish. So Art City Scuba, if anyone's interested, on the first Sunday of December we do a paddlefish dive.
I've been wanting to go to France Park
First Sunday of December.
for December. Yeah.
Yeah, definitely.
I want to do that.
Yeah. If anyone else wants, maybe I'll post it this year.
Yeah, post it.
Yeah. So basically, they open it up for us so that we can do a dive. If you're careful and don't stir things up, the visibility is usually spectacular. Once somebody goes down there, it's only about 20 or 30 feet deep. So once somebody hits the bottom, then you get a big cloud of silt up there. But so anyway, the goals for the presentation, if anyone's watching or anyone needs CME credit, I claim Category 2 credit for this. If you come to my course, you can claim Category 1 credit, but you'd have to take the quiz. So basically, these are the objectives that I had. For us, I want to just kind of get familiar with what we go through deciding who should dive and under any sort of restrictions or considerations that might come into play, like we talked about before during the introduction. And just a reminder, this is just kind of general informational. I'm not giving you medical advice right now. If you need medical advice, either you got to see your physician or actually come and see me as a patient.
There you go.
So, so anyway, but basically this whole topic, the whole issue of who can dive and fitness to dive is a massive topic, and it's the subject of going courses where we spend like days talking about this. So the scope of a 1-hour presentation is by nature limited, but generally we want to kind of describe the approach, and as well as what Dr. Mitchell describes as a generic method for assessing the impact of any disorder a candidate might report. One of the things that we face is in diving is the difference between recreational and like professional diving generally is in our approach. For a professional diver, we usually what's called a prescriptive approach, which basically means that there's a list of conditions. If you have them, you're out. With a discretionary approach, it allows us to use a little bit of judgment and sort of weigh risks and benefits. I mean, just to pull one out, let's say somebody's taking aspirin for heart attack prevention or something. If you're a commercial diver, you're basically done. You know, if you're or let's say you've had a heart attack and you had a stent put in and you're on aspirin for it now. If you're a commercial diver, you're done. If you're a recreational diver, we can use some discretion about that and say, yes, you're at increased risks of having a heart attack, and weigh the risk and benefit ratio and discuss it with the person, maybe alter their diving, that kind of thing, you know, dive under, you know, less strenuous conditions as much as possible. But it gives us that option. So basically, both of them start with a medical consultation and identifying the problems. With the prescriptive approach, we just look at the list of things that exclude you. If you have one of them, then you exclude the candidate and sorry, no diving. One of the sad things, unfortunately, is people want to go to be a professional diver and they go to dive school and they might have their personal physician sign off on their diving certificate to get into dive school. And then when their company, when they see a dive medicine professional, this has happened a lot, where then all of a sudden they find out after investing $30,000 in a year of their life that they can't get certified. So as opposed to a discretionary recreational exam, we can have a risk-benefit discussion, decide how much risk you reasonably want to take, and then endorse diving if the risk-benefit ratio is favorable. Now, that being said, it's not a license to throw caution to the wind. There are some conditions that you just can't dive with, you know, and just throwing out, if you have a history of a seizure disorder, for example, you can't dive, you know, because the consequences of it are too great. And the other thing is the dive physician actually owes a duty not only to the diver themselves. They can say, yeah, I don't care, I'm fine. I love diving so much. If I die underwater, that'd be a good death. But on the other hand, it's going to affect your dive buddy. It's going to affect everybody else on that charter. It's going to affect the dive master and everybody. So we have to take that into account as well. So this was that was actually in the Philippines in April Reef, eating my little clownfish there. And as you all know, this is kind of review for people in this room. When you do your recreational diving certification, you have to undergo medical screening prior to beginning your dive training. But once you do your dive training and get your certification, there are no ongoing medical requirements. The dive certifications are lifetime. There's some operators or countries, Egypt, for example, that have more stringent requirements and may have you fill out a medical form. And more dive operators are having people fill out medical forms. We typically use what's called the RSTC, which is the Recreational Scuba Training Council, which is a consortium of the UHMS and some of the training agencies and everything that put the medical form together. The other thing to keep in mind too is even if you answer no to everything on the RSTC form and sign it off and everything, if you do have an accident, more and more of the insurances might say, well, you didn't report that on your medical form, we're not going to cover you. So, you know, one of the things is you may kind of get away with it, but, you know, then if you get hurt, you may find that you don't have insurance coverage either.
And some operators I know just sort of hint, just say no to everything.
Well, when I was in Egypt, they basically said that when people who didn't have the form, they're like, well, you'll have to fill this form out and answer no to everything or you can't go diving. And there were people who were over 45 who were answering no to the under 45 or to the over 45 question.
Yeah.
So, I mean, it's like...
Well, the thing is, many people over 45 are on some type prescription medicine.
And that's another one of the questions. And the prescription meds, except for birth control or malaria medicine, needs a physician consult.
And some of my doctors, especially my PCP, who's quite knowledgeable about that medicine, has an issue with that.
Yeah.
About like they're ballparking too big a thing. That
Yeah.
There are some, if you told the truth, they'd say no, but it'd be like,
Yeah.
no.
And but anyway, we're getting to that in a moment. So anyway, as you can see on your typical certification card, there is no expiration date on there. So that's good. I could be in bed senile, and I'd still be qualified to dive by my certification. So as we said, open water certification. allows independent planning and execution of dives with another certified diver within limits of the certification, which includes depth, gas blends, and equipment, including such things as dry suits or using diver propulsion vehicles, aka scooters. In fact, open water certification certifies you to dive down to 60 feet maximum. And part of the reason why that was chosen is, among other things, it's very hard to run out of no eco time if you're staying shallower than 60 feet before you run out of air. So it provides that safety margin. If you're going deeper than 60 feet, you're more likely to go into decompression, which can increase your risk of decompression sickness. And so, at least by PADI, it's 60 feet if you're open water, it's 100 feet if you're advanced, and 130 feet if you're deep.
So that's an interesting
And the other thing,
topic of discussion, I guess I would say, because if you look at what PADI says, they say 260 feet or the previous or like the limit of the depth of your experience.
yeah,
Which means to me that if you are one of those people that is gradually pushing your experience down, then you're sort of certified.
and the thing is, as we know, there are no dive police. Now, on the other hand, and some operators are more strict about this than others. Like, for example, on double action, they won't let you dive to a wreck that's deeper than 60 feet if you're not advanced certified. Now, on the other hand,
however, I've only encountered one or maybe two people that would not let you dive 100 with it.
yeah, a lot of them will, but that's up to the operators.
Yeah.
There's a lot of gray areas in this.
Right. Yes.
The other thing too is you say independent planning and execution. We'll just touch briefly on disabled diving. That SSI actually calls it classified diving.
SSI is a certification agency.
Yeah. So SSI is like PADI. It's an up and coming. It's actually rapidly growing certifying agency. But basically, all the certifying agencies follow the same ISO standards, whether it be PADI or SSI or NAUI or SDI. They follow. There's an ISO standard for the skills that you have to do to be open water certified, and for nitrox certification, they all follow the same standards. So they may teach it a little bit different one, but they're teaching the same. They're basically teaching the same skills. But anyway, so people with paralysis, amputations, blindness, and deafness are able to dive safely, and often they've described it as being liberating. Sometimes somebody who's paralyzed, for example, they can get in the water, and all of a sudden, with that buoyancy, they have a lot of freedom that they don't have. But they're actually certified only to dive with other divers, which can require more than one depending on their disability, who are themselves certified to work with the classified diver's specific disability. So the certification to buddy up with a blind diver would be different than the certification, say, for a paraplegic diver or a quadriplegic diver. So that was, I just wanted to touch on that for...
I saw a video from dive art not too long ago, and I noticed the guy in the water is not wearing any fins. Oh,
yeah.
And
for people with paraplegia, sometimes they'll use like hand fins, because they tell you not to swim with your hands because it's very inefficient. But if you put fins on your hand, then all of a sudden you can be more efficient swimming with your hands. So I just wanted to touch on that because people sometimes would ask, well, hey, you're not going to let me dive, but then this quadriplegic can dive. It's like... the other thing to remember with recreational diving is all recreational dives are optional, and they mentioned this when we had the person from the Chicago dive unit here. We get to choose based on the weather, the conditions, how motivated we are. If you don't like cold water, you don't have to dive in cold water. If you don't like diving in raw sewage, you don't have to dive in raw sewage. The fire department doesn't have the luxury of that choice. They have to dive wherever their mission takes them. It's a little bit like recreational aviation in that in aviation all takeoffs are optional and all landings are mandatory. So with the diving, the descent is optional, the ascent is mandatory. So occupational diving doesn't have that flexibility, which increases the stress the divers have and the overall risk, which we have to take into account. Anyway, so just a few pictures for those of you who have been there. They moved around a little bit, but this is Bonterre Mine. Unfortunately, it's closed right now. Hopefully, it'll reopen at some point. But this is the dive deck down here. This is actually 100 feet below street level. So you basically have to hike out of the mine on the way up, which doesn't help as far as not provoking decompression sickness. And there's sort of some of the underwater smoke that they show you, which is dissolved minerals in the water, and and then some light bulbs floating on the ceiling, which kind of moved around a little bit there. We'll get into some other modes of diving with public safety diving. With public safety diving, there is actually no specific governing body. The other thing is in the OSHA regulations, which govern, there's actually Section T of the OSHA regulations cover diving. There's a specific carve out for teaching, for an instructor as an employee teaching recreational diving on air within no decompression limits. For on nitrox with no decompression limits, they have an exemption from having to have a chamber on site. But again, this is one of these things that nobody's going to say anything until you have an accident, but it's kind of a gray area right now. So whether teaching recreational diving counts, whether you're covered as an occupational diver or not, is a very gray area, because it does say very clearly if you go into decompression that's not exempt from the occupational diving standards. So we'll let People's Legal Counsel figure that one out. So the other thing too, as far as certification, a lot of cases, fire departments will have either person's primary physician or their occupational physician sign off on the certificate. That person signing off may or may not have diving experience. For some reason, the color switched on this one slide, so sorry to blind you here. As opposed to commercial diving certification, that requires initial and ongoing certification. And basically, there are two commonly used standards. There's the Association of Diving Contractors International, or the International Marine Contractors Association DMAC standards. The DMAC is recognized internationally. So if you give somebody a DMAC certificate, they can basically dive anywhere with that. To do one of these exams, for a DMAC exam, the physician has to be certified in order to issue it. If you are not certified and you sign off on a DMAC and they present it somewhere, it will not be accepted. They will check the list of authorized DMAC physicians, of which there are relatively few, and they won't accept it, and their medical will have to be redone. ADCI, you can, we've got it backwards. The letters are reversed there, but ADCI technically you can do, but you really shouldn't. And I aim this at my colleagues, that if somebody comes to them with a request to do a commercial diving evaluation, to send the patient to me and not do it themselves. So, also it's the examination. Literally, I need an hour slot to do the exam. It's very thorough, So it's and it requires a lot of testing, everything. The other thing is they have to be recertified. They have to be recertified every year.
Oh, really?
Yeah. Military, as I said to my colleagues, they're certified military physicians. You won't see them unless you're a military physician. Scientific diving is a little bit different. Sometimes people do scientific diving, on a recreational certificate, so it's fairly variable as far as
What do you mean by scientific diving?
like if you're doing, like say that you're going out and counting fish or doing something as part of a science project, like an environmental study or that kind of thing, so
not citizen science, but
no, as part of
Rotary University,
as part of a structured activity. So, if you're going out there and say, like people watching the coral over time or something like that kind of thing. If you're doing an actual bona fide science project that's actually supported by somebody that has a dive safety committee, and so a lot of times it's something like counting fish or whatever else, and or logging appearances of stuff. Depending on who's sponsoring it and everything, they might let that type of diving. They might let you do it with a recreational diving certificate, and then you still need certification, and the medical certification is governed by the American Academy of Underwater Scientists, and they actually require for somebody under 40 to have an initial medical certificate, and then every 5 years, the Q is medical terminology for every. So less than 40 every 5 years, every 3 years for 40 to 60, and every 2 years if they're over 60. And basically what we have to do every time, we have to do a history and physical exam. We have to do blood count, the UAs of urinalysis. At their first encounter, or at 40, or their first examination, we have to do a chest x-ray, we have to do spirometry, which is a pulmonary function test. And then after they're 40, we have to do an EKG and a cardiac risk assessment. And depending if their 10-year risk is greater than 10% on the Framingham, then we have to do additional testing like a stress test. So it's a little bit more involved. And then this is what I was saying, the gray area for OSHA has a specific exception for a recreational instructor, but it specifically states for dives within the no deco limit. So for tech instructors, it's questionable. The problem is that once you're doing decompression diving, OSHA says that you have to have a recompression chamber on site. Interestingly, if you're doing recreational training on nitrox, because it's not air, then the only thing you're exempt from is the on-site chamber. But the regulations say that you need to confirm that there's a chamber and a physician available within 4 hours, including transportation available, that you have to confirm that before you begin your diving activities. That's what the rules say. I've never seen anyone do it, quite honestly. There I am. I can't remember which. I think that was in the British Virgin Islands, but I can't remember. I don't even remember which wreck that is anymore. But it was kind of cool. So I'm there taking a picture of it. So the other thing that we can look at,
The certifications that are involved, how much different are they from recreational diving?
the what?
The certifications themselves, what did they?
Commercial diving is a big deal.
Well, that's completely different.
Yeah. And it depends for public safety diving. Some departments will actually have divers with recreational certificates doing it. Because a lot of times it's shallow diving. Sometimes like a rescue diver certification. The other thing is SDI actually offers they have a pathway. It's which one is it? Forgetting the acronym right now. It's part of the SDI TDI agency. ESDR, or I think it is. But they actually have a course for for basically public safety diving. So it depends on what your agency wants. I mean, people can take somebody with a recreational certificate and train them internally. Some will
How about
require scientific diving. It's the same thing. It depends on what you're doing. That some of them will take people with recreational certificates and
add on to that
and teach them the tasks of what they're doing. And one of the things that we're encouraged to do when evaluating them is to remind them that you're going to have a task load, even if it's just counting fish. So you want to make sure you're experienced as a recreational diver, so you don't lose control of your buoyancy because of what you're doing or run out of air.
Not just buoyancy, but if you're concentrating on something other than your diving, which is what you're doing.
Yeah.
You forget things like air.
Yeah.
Also give it your depth. Time.
Everything.
You dude, I ran out of air on an archaeological sketch, right?
Yeah.
And so it's
easy to do. Oh, that's another thing also that OSHA requires is if you're doing a covered dive as an employee, you're supposed to have a redundant air supply. But anyway, and then this is more aimed at my non-diving colleagues. I say, many activities, parts can be very serene and relaxed, like looking at Nemo here. But all of a sudden, the stress can go up dramatically. And of course, I pointed out that the reason the stress goes up dramatically is because I've got to swim as hard as I can to chase this shark, which is a very good swimmer, so that I can get a good picture.
I'm trying to get to that shark.
I'm trying to get a good picture of this shark, and it's swimming away from me, and it scared me. So anyway, the Newman and Tom is the definitive textbooks of hyperbaric medicine, and some of this also I can refer you to Simon Mitchell's chapter in this textbook of clearance to dive and fitness for work. Oh, did you want?
I got it. Yeah.
It'll be on the YouTube channel too.
Oh, okay.
Wait, so
yeah.
the other thing to keep in mind that we have to think about is non-diving accidents can happen in remote locations, and a lot of times we dive in remote locations.
Just keep going.
Yeah, we can dive in. Diving often occurs in remote locations where medical care may not be readily available, and so we have to base our overall health assessment and risk for needing medical care in general as well on deciding where people might want to go. So anyway, here's an example here of a remote location. This is one that Dan always talks about as one of their worst places, some of their worst places to evacuate people from. Okay, the first one here, they're both in the same screen. The first one here is Cocos Island. Who's been to Cocos Island?
Yeah.
Yeah. Okay.
Popular place.
Yeah. The thing is, in order to get to Cocos Island, it's a small. I don't have a picture. Oh, I do have a picture coming up, but it's a small uninhabited island in the middle of the Pacific, several hundred miles from its territory of Costa Rica. But it's several hundred miles. It's 36 hours by liveaboard from the Costa Rican coast. You actually go. You start up on Punta Arenas, which is a little further north of San Jose. And you take your liveaboard there and you stay on your liveaboard. There are some rangers who have basic first aid skills. The Costa Rica does not have a military. Their Coast Guard does not have any helicopters that can make a round trip there. So there's no way and there's no airport on the island because it's only a few miles across and it's mountainous. So there's no way to do an air evacuation there. If you wanted to get an long-range helicopter, it would take longer to get it in. So in order to evacuate somebody, it takes 24 hours. So basically what they have to do is get a speedboat. The liveaboard has to start heading back and then meet a speedboat about a third of the way and then take it back in again. So it's a very big deal. So if you have a heart attack or something there, you're going to have to be temporized for at least 24 hours before you're going to get any medical care. The other one too that's more challenging is these guys here. This is the Galapagos Islands, and the popular spots for diving are Wolf and Darwin, which are up in here, and they're also uninhabited, and they're about 12 hours by boat from the rest of the Galapagos. So that's another area where it's difficult to evacuate from. And here is lovely Cocos Island. It's the smallest island in the world that has a tropical rainforest. It's only several miles across, and it actually has flowing waterfalls and everything, and a fairly high mountainous peak. You hear birds chirping. Apparently part of Jurassic Park was filmed there. Why do people go to Cocos Island? Because of the sharks. And it's some of the most shark-infested water. So you see a lot of these scallop hammerheads. We saw like whole schools of them. The water is nice and clear. The other thing too, it was the only time that I ever saw a whale shark in the wild. I actually took that one. But things can happen. In matter of fact, when we were crossing to Cocos Island, 12 hours into the crossing, one of my fellow passengers didn't listen to the instructions about facing the ladder when you walk down, and walked down facing away from the ladder and fell down and dislocated his shoulder 12 hours from shore. So the captain came banging on my cabin door and told me that we had a hurt passenger, and he cut his foot and he dislocated his shoulder. So we didn't even have a gurney, so on the deck, I was having the crew give me counter traction and had to reduce his shoulder. And I tell the captain, if I can't get it back in, we're gonna have to turn around and go back. And then they had a fairly comprehensive first aid kit, but they didn't have any dermabond, so I had to use super glue from the engineer to repair his foot. So I was able to put him on antibiotics. He was actually able to do the dives, and we were able to continue our charter. So, but the other thing too that happened when we were in Cocos Island, we made the national news in Costa Rica. For those of you who don't speak Spanish, boat with 13 people capsizes in Cocos Island. The boat tourists who were set to begin to dive. So we were basically on Zodiac off of our liveaboard, and a wave hit it, and we had just gotten in the water, and it flipped the boat over. And so there we are. The news back on the mainland was that a bunch of turistas were in shark-infested water when their boat went down, and they were rescued by the Rangers. So the Rangers filed that report. So
This trip is familiar with what Jeff does.
yes, well, yeah, I know. And my luck went with me to Costa Rica twice, because the second time I was in Costa Rica, we had one of the dive boats sank during our diving operation.
That's not good.
No. But it was freshly serviced.
Oh, just so.
But so anyway, in order to decide whether somebody should dive or not, we want to think about what are some of the stresses we encounter. We know since we're divers that humans don't have gills. But one of the things that happens when you get in the water is you get a fluid shift. So we all know what happens when we get in the water and want to go diving. Well, all of a sudden we want to pee, right? So what tends to happen is you get what we call peripheral vasoconstrictions. The blood vessels clamp down, squeeze basically some of the fluid into the bloodstream. Your kidneys go to work peeing that out, and then you have to go to the bathroom. And so up to about 750 cc's of fluid can make it into your circulation just when you get in the water. So if you have a weak heart or something, that can be an issue. The other thing too, in water is much more conductive of heat than air. You know that getting into 80-degree water is very different than going in 80-degree air. There are also psychological effects, including claustrophobia, marine life, and if you have, as we talked about, underwater emergencies or problem solving that we have to worry about, that can increase your psychological stress. The other thing we're all aware, go through this quickly because we all know it as divers. Ambient pressure increases rapidly in the water column, so basically every 10 meters or 33 feet that you drop down, you get an extra atmosphere of pressure. So your pressure doubles from the surface to 10 meters. And then it goes up 3 atmospheres when you go down to 20 meters and 4 atmospheres when you go to 30 meters. The important point here is that your greatest percentage of pressure change occurs closest to the surface. So your chance of hurting your ear or something is greater near the surface. So people can injure their ear or something in a swimming pool just as easily. And the other thing to remember is when you do your safety stop, I can't tell you how many people that I see finish their safety stop and they pop up to the surface. And that last 15 feet is the most critical part of the ascent. And when I'm diving, I try to take a full 60 seconds to get up to my safety stop and ascend even slower than I did to my safety stop. And as we know, gases are subject to Boyle's law, which is basically the pressure-volume relationship at gas. So mathematically, pressure is inversely proportional to the volume. So if we double the pressure, we halve the volume. Or if we could say we halve the volume, we double the pressure. So if you squeeze the gas to half its volume, the pressure will double. On the other hand, if in a constant volume, if you double the pressure, you have twice as much gas in there. And we use this in order to know how much gas is in our tank because our pressure gauge tells us it's proportionate to the amount of pressure in there, which is proportional to the volume of gas in there. So in order to maintain a constant volume of gas in a given space in a changing pressure environment, we have to add or remove gas from that space. So that's what we're doing when we're equalizing. The pressure is increasing. We want the volume inside of our middle ear to stay the same and the volume inside of our mask to stay the same, so we have to add air to it. So we do that by equalizing, or we do that by exhaling into our mask through our nose. And other air spaces like your sinuses should just equalize automatically because they're connected together unless you're congested. So anything that hinders the ability to equalize is problematic. So if somebody's eustachian tube doesn't work, the tube that connects the inner ear to the back of the throat, if that's clogged up like it does when you get congested or if you have issues with it, then you won't be able to equalize and you'll have problems. If you have COPD, you can get air trapped in your lungs, which can be a very big deal because the air can get in and then when you're going back up, it can't get out again. And if it's stuck in your lung and it expands, it can tear the lung and cause the lung to collapse, or it can dissect into the bloodstream and cause an AGE, which is very serious. The other thing is any pathologic gas spaces. We talked about dental pain before, like if you have air underneath the filling or something. If you've had surgery on your eye, for example, if you don't wait long enough and you have an air bubble in your eye, that can compress and expand. If you've had any other surgery, then that's part of the reason why we wait after having surgery before we go diving. The other requirement is our divers. These are some of the things you have to do when diving. We got to acquire and apply relevant diving theory like gas laws. We have to be able to work as a team in order to adhere to a pre-agreed system and a dive plan. We need to tolerate the psychological stress of total immersion in water that's well beyond standing depth. As I say, I tell people there are only 2 depths of water. There's water that you can stand up in, and there's water that's too deep to stand up in. If the water is 20 feet or 1,000 feet deep, doesn't make too much difference in general, but except for psychologically. The other thing is that we're going to have to lift and carry individual items of diving equipment on land. I don't know how many of you, when you took your open water course, had to learn dive tables.
Do they still teach psychology?
No.
They don't.
That's a shame.
And I think that they really should. And for the same reason that you teach kids to do arithmetic by hand before you let them use a calculator, that it's a really, really good idea to use a dive table so that you have some, or at least to calculate your dive doing a dive table, because you get an idea of how reasonable a dive you can do. You know, that you can't just dive until your computer says that you've run out of time. You get an idea going in about how much dive time you have. So basically, you have to look at the depth that you're planning to dive to, and what it'll do, it'll tell you then how many minutes you have at that depth, and you would have to round up basically every time. And then you have to figure out, when you get there, it gives you go across however long you were actually down, you go across to that letter group, and then that letter group figures out how much nitrogen you have left, and you have to go to the other side, and then that figures out how many minutes to add to the next dive before you start it for a repetitive dive. So you kind of go around in that circle every time. So the first dive you could start at the top, but then for every subsequent dive, you have to figure out how much nitrogen was left from the previous dive. So you figure your pressure group by that letter on the left, you go across, and then you look at how much time you've been out of the water and how deep you're going to go for the next dive. And then you go down to find your new pressure group, which will be lower than your old one. You take that new pressure, you take the surface interval, however long your surface interval is, figures out your new pressure letter. Then you take whatever depth you're planning to go for the next dive, and that tells you how many minutes to add to whatever you're going to do there. So you're going to have less than you would originally. And if you go through and do this, then you kind of understand what your computer is doing, and you have an idea of what's reasonable and what isn't.
So one of the things about the dive table is it does give you a more conservative dive, sometimes substantially more conservative. And sometimes that's a good thing. And I often use the dive tables. I mean, I always use the dive tables after a dive, because I always keep a logbook, and I use my dive tables for the logbook to run my computer, keeps track of my dive there, and I look at the difference between what the tables tell me I should have done and what the computer says I could have done. The computer always gives you an advantage.
The computer will give you a big advantage, because one of them is for the dive tables have they're in 10-foot intervals. So you always have to round it down to the next deepest 10 feet. So if you're diving 55 feet, you have to round it to 60 feet.
Plus, the dive table always goes by your deepest.
And it's a square.
It assumes a very square.
It assumes a square profile.
Yeah.
It also, the way that by convention and by the way the table is designed to be used, the time starts on the surface, not when you actually reach depth, and then the dive ends when you start your ascent. So your bottom time is from the time that you start your descent to the time that you begin your ascent. And that was on the open water quiz a long time ago.
Yeah.
And the other thing that's also interesting on this table here is these little gray areas here. Okay, if you're 100 feet or deeper, those numbers are in gray. Or if you go for a long time on some of the shallower dives. Well, the gray, if you look at the side, it says safety stop required. Okay, well that's a little bit of a fudge factor. A technical diver would call a required safety stop. They have another name for it. It's called a decompression stop. You know, and the other thing that's interesting with how they came up with the safety stops, this is just an aside, is that these tables are based originally on the U.S. Navy tables. The U.S. Navy tables were designed for like young, fit, healthy Navy divers, and when they started using these tables, when they adapted the Navy tables for recreational diving, too many people were getting bent. So they put in the safety stop as a fudge factor. So it's basically, it gives you that margin of safety, but it basically is a decompression stop, And the other thing too is following the table or following the computer, just to remind people, does not guarantee that you will not get bent. What it basically does is it reduces the risk of getting bent to a reasonable level.
It doesn't tell you what's actually happening to you.
Yeah.
It just gives you a theoretical.
It's a theoretical approximation. It's interesting because with computers we'll use different algorithms sometimes. If you and your buddy, if you stay like right next to each other and you're using a different computer, you might find that you have different amounts of bottom time. And so anyway, the other thing that you need to be able to do, some physical requirements, we have to be able to stand up from a sitting position and walk approximately 30 meters without fins and standard scuba equipment. This is from Dr. Mitchell. Showing just a recreational scuba unit on a scale showing it weighs 23.6 kilograms, which is about 51.5 pounds. When we start doing cold water diving, there I am in cold water gear. That can be approximately 100 pounds of gear by the time you get extra weights for your dry suit, steel tank, and everything. And there I am in Lake Michigan.
That's only with one tank.
Yeah. And no, I mean, if my double 130s, just the tanks weigh, about 130 pounds, plus everything else. So, I mean, it can get very heavy very quickly. And if you start doing a technical dive, it can get even heavier if you're taking a bunch of stage bottles and everything. In fact, some tech instructors will say that the number one reason people fall out of tech training is because they don't have the physical stamina to do it. So anyway, and you should be able to climb a 1.5 meter vertical ladder to get out of a boat or get out back onto onto a dock or something, wearing standard scuba equipment. You got to be able to equalize your ears. You should be able to swim underwater at about half a knot for 30 minutes in standard scuba equipment, which works out to about 5 or 6 mets, which for those of you, a met is what we call a metabolic equivalent. And basically it's 3.5 milligrams per kilogram per minute is the definition. But what it really means is us all sitting here are about doing 1 met of activity right now. It's basically when you're resting, that's the activity you're doing. If you're driving a car, it's about 2 mets. I'm probably doing about 2 mets right now because I'm sitting here talking to you. But a power walk would be about 5 or 6 mets. Running at 10-minute pace would be about 10 mets, and running at about 7.5 to 8-minute pace would be about 13 mets.
Never heard that.
Yeah. Yeah, it's a fairly common in exercise physiology. So, but the other thing you should be able to do, because you might have to swim against a current, which is why we want you to be able to do like about a half knot swim. Swimming 1 knot would be if you have to get out of a current or something like that or get back to a boat. We want you to be able to swim 1 knot for about 3 minutes. So where the fitness requirements come from is you need about 5 or 6 mets in order to swim at that half knot. So the other thing is we want you to be able to maintain a protected airway with a submerged mouthpiece in place when totally submerged so you can't have anything wrong with your mouth. You want to be able to see and have at least recommendation is 20/40 vision corrected. I have the luxury of having my prescription incorporated into my dive mask. People will wear contacts while diving. You can't wear glasses while diving, obviously, because of the mask seal. So, either you can get like fixed corrections for your dive mask that are sort of close. I mean, like I have astigmatism, so I have my astigmatism in there. And the other thing is too, you can't like take your glasses off to look at something up close. So, so I have my focus in my mask. And because it's just not an option, you can't look under your glasses if you're underwater. So, so some of these capabilities are actually beyond my capability to assess. So the diving instructor has an important role here too. So a lot of times we don't say fit to dive, we say more, I can't find any conditions incompatible with diving. And on the evaluation form, we're asked to basically say either we approve or we don't approve. The old form used to actually let us put comments in. Now it's like there's a battle between the instructors and the physicians because the instructor wants to say, well, I relied on the physician wants to say, well, I'll leave that to the discretion of the instructor. And so we can tell the patient what we think, but we basically just have to either approve or disapprove them on the film.
Is it a liability?
Yeah, I mean, it was kind of what was, I think that they don't, that they don't want to be liable for anything. Yeah. So they don't want any conditions on the form. But if I tell somebody don't dive deeper than 40 feet, for example, or dive conservatively, then I can put that in their medical record, which means that if something happens to them, hey, I told you that you weren't supposed to dive deeper than 40 feet, and I told you to use nitrox on air settings, and you chose not to follow that recommendation and you got in trouble. So, I told you, it's like, so what we usually do is the candidate diver will fill out the form, and they generally won't come to me unless they answered yes to the screening questions. Because if they answer no to all the screening questions, they're good to go without a doctor's signature. The old form started with could you be pregnant or attempting to become pregnant, and I remember one time I filled that out as NA, and they wouldn't accept that. I had to put no. And okay, and then they have the over 45 questions. If you're over 45 and currently smoke, have high cholesterol, family history of heart attack or stroke, are currently receiving medical care, high blood pressure, or diabetes, even if controlled by diet alone. Well, that's probably most people who are over 45. So technically, you should be saying that.
What does currently receiving medical care?
That's vague.
What?
That's vague.
It is very
Yeah, but this is the old form, so we don't have to worry about that anymore.
Oh, okay.
So anyway, but the other thing too is that they ask if you have any dive accidents or decompression sickness. Okay, now the new forms. Okay, they've changed it a little bit, and so basically what they basically ask is they do a systems-based review. Any problems with your lung or breathing, heart, blood, or been diagnosed with COVID-19. And if you answer yes, then there's a separate set of questions. If you answer no to all of those, you're okay. Are you over 45? Yes. Then you have to go to box B and so forth. If you struggle to perform moderate exercise, the box with the star next to it means you got to go straight to the doctor. So if you struggle to perform moderate exercise or haven't been able to participate in normal activity, you got to have an exam. Or if you're taking any prescription medications except for birth control or anti-malarial drugs other than methylquine. We don't like methylquine because it can have side effects that are similar to DCS. So generally, we recommend if you're going to take malaria prophylaxis, take something besides methylquine. Tetracycline is my choice for most areas, but you have to check, see what's endemic. So, and then we'll just look at the over 45 questions. If you currently smoke, if you have high cholesterol, high blood pressure, or close blood relative die suddenly of cardiac disease or stroke before 50, or have a family history of heart disease before age 50, including abnormal heart rate, coronary artery disease, or cardiomyopathy, then you need to do that. And then we look at the risk basically and decide whether you're good to go or whether you need to do a stress test first. These are some of the rest of the questions here. As I said, none of us are getting any younger here. Can you recognize this group?
Yeah.
So I shamelessly stole this from our website. So here's this was a picture of some mating squid that I took in Bonaire. It's really cool to watch them mate because they like change colors. They actually have they can change their colors voluntarily. They have chromophoric cells in their skin that are under neurologic control, so they can change their color very quickly. Squid and octopus have that.
Are octopus colorblind?
I don't know.
I thought that they were colorblind, but they still could change.
Yeah, I don't know actually, but they can camouflage. This is a mandarin fish. This one I took in Indonesia. That was on our.
Yeah. I've seen it.
Yeah. So anyway, what diagnostic tests do we need to do? And we get to the lying on the form or misrepresenting things on the form. Basically, diagnostic testings isn't likely to yield anything that you're not going to find on a good history or exam. The only thing is basically patients with cardiac risk factors, it's probably worth looking them up. So they actually found, this is from Dr. Mitchell, assuming a good screening questionnaire, the chance of finding a significant problem in face-to-face medical is not revealed by the questionnaire is very small. And they actually studied it, and they actually found, this was in the British Journal of Sports Medicine, that basically in questionnaire versus medical evaluation out of 2,962 people, no important medical problems were missed by the questionnaire.
Well, the question I have as far as going to your doctor, be cleared for diabetes, do they have that? You showed a form,
Yeah.
and is that form generally available, or is that something they have easy access to, or do they know about?
If you go to your regular doctor, they're not going to know.
Yeah.
Usually what happens is whoever the dive operator is who wants you to get a medical gives you the form or tells you where to download it. You can download it from the UHMS website, but basically usually they'll tell you that you got to fill out an STC form, or they'll give you the form and say fill out this form, and if you answer yes to anything, you got to go see your doctor and have them sign.
At what point do they ask you this question when you're on the dive boat?
Well, and that's the thing, because originally this was supposed to be used before you started dive training. So when you went to the dive shop and signed up for the course, that's when they would give you the form. So yeah, they probably did, and you probably answered no to everything and started your training. So.
Yeah, I heard.
Yeah.
Years down the road.
You have to do
things
that
change.
every time you do it.
Every time you do a course, you have to
Yeah.
do that. Like if you do another certification.
Oh.
So the and then this one here, basically same thing, that they looked at 632 out of 1,000 students who answered no to every screening question on the form. 9 out of those 632 subsequently, quote, failed a face-to-face medical exam. And some of the reasons for, quote, failure were debatable, as they said, that 3 of them failed to meet arbitrary PFT targets, and 2 were supposedly failed because they were unable to equalize during their medical exam, but that would have been detected, or they would have been taught how to equalize when they're taking their dive course.
How do you equalize during a medical exam?
Yeah, you insufflate your ears, and we look with the otoscope and watch the eardrum movement.
But,
Yeah, you do like a Valsalva maneuver and pop your ears, and we look for the eardrum movement.
oh,
Yeah. So
it just proves that you know how to do it.
yeah, and it proves that you can do it too. As far as returning to diving after you get bent, this is DMAC guidelines. For limb pain or non-specific findings, uncomplicated, you can go back to after 7 days. If you need more than one treatment or if it's recurrent, it's 14 days. If you have cutaneous or lymphatic DCS without neural involvement, you can go back after 7 days. Neurological DCS, but without visual, cognitive, brainstem, etc., 28 days. If you have pulmonary DCS or any of the above neurological problems, then it's 3 months. The ones that are highlighted in yellow mean that you need to have a dive specialist evaluate you before you go back. If you have pulmonary barotrauma, 3 months and you need a chest CT. Cases requiring multi-treatment or residual neurological defects, it's case by case and a 3-month minimum. That's for commercial diving. For recreational diving, GAN recommendations, pain-only DCS without any neurological symptoms, you can go back to diving in 2 weeks. Minor neurological symptoms with resolution, 6 weeks. If you have severe neurological symptoms or residual symptoms after treatment, then they recommend you don't dive. And that's the difference between somebody doing it for their livelihood and doing it for fun.
Yeah.
So anyway, nice big grouper here. The other thing too, getting towards the end here, but
Okay.
yeah, is 27% of the time when they looked at in Australia at diving fatalities, a cardiac event was a disabling injury. One of the things is a lot of times a medical examiner who may not have any dive training will probably just sign it out as a drowning. If you're in water and you have scuba gear on, you die, you drown. But the thing is, what was the initial thing that caused that spiral down? And cardiac events are one of the most frequent disabling injuries that ultimately lead to a diver's death. And that's why we're careful about screening for them, and why as people get older, if you look at like the cardiac risk scores, one of the biggest things that increases the number of points on your Framingham score is how old you are. So as you get older, you're at higher risk, which is why we're more careful about cardiovascular disease. Also, why divers should exercise outside of diving. Diving is good exercise, but most people don't do it often enough unless you're in the industry, unless you're working as a DM or something. So as they say, you don't dive to exercise, you exercise so you can dive. So cardiac issues, another study contributed to more than 50% of deaths. Most common dive injury, though, is otic barotrauma. But that's usually not fatal. Usually people
It's
recover.
otic. Your ear. Yeah.
Yeah, yeah, exactly.
You are. You're pretty.
That's the most-
pretty standard.
Hey, I perf my eardrum in the swimming pool.
Oh, there you go.
Yeah.
I don't feel so bad.
Yeah. And the disabling injuries that are often associated, and these are all different things that with their odds ratio basically shown there. Entrapment, running out of breathing gas, and buoyancy or equipment problems. So running out of breathing gas is a big one in the
They
making.
don't have being eaten by sharks in there.
No. Trauma is which is frequently associated with rough water. Cardiac events, as I said, having a previous cardiovascular disease has an odd ratio of 10.5 as far as the likelihood of causing cardiac death, or age over 40. Decompression sickness associated, odds ratio higher if you're diving deeper than 180 feet, if you dive alone, or if you make an emergency ascent without decompression. Well, no kidding. Okay, so anyway, this is also from Indonesia, pygmy seahorse. I could hardly see it when we were actually diving. Our dive guide actually pointed it out to us.
out to you.
Up our scales,
Yeah,
scales wrapping
yeah,
around.
the dive guide, you can see the eye there too, right there. The dive guide pointed it out to us, and it was like, I just took a picture where he was pointing. I couldn't even really see what I was taking a picture of. So one of the things, again, approaches to individual disorders. As I said, there's a lot of different things that could bring a patient to a diving evaluation. The more common and significant ones are well understood, but a lot of times you're going to be thrown a curveball. And so this is where we come up with the 3-question approach. First one is, you have a condition that could be exacerbated by diving. An example would be like if you have angina. Okay, well, if you have angina, you could have chest pain because of the stress and exertion of diving. So that's The second one is, does the patient have a condition that could precipitate a diving disorder? And so like an example is sarcoidosis, which is disease of the lung, which could predispose to gas trapping and cause pulmonary barotrauma. So it's, in other words, can the disease be aggravated by diving, or can diving aggravate the disease? Are these two questions. And then the third one is, do they have a condition that could compromise consciousness or physical performance in the water? So as an example I mentioned earlier, epilepsy, which could lead to sudden loss of consciousness. And obviously that would compromise performance in the water, and
That would
probably won't end well.
performance.
Yeah. Here's another one. This is from Indonesia also.
Yeah,
This was,
I can
this
see a
was
nice clean shell.
the nice clean shell on the turtle. This was on the Monado side.
They scraped under the coral.
Yeah, so they scraped their shell.
I saw one of them do it.
Yeah. So what I thought I'd do, and we're almost done here, is a few common conditions, to go through the 3-question approach and the typical outcomes for these. So, for example, somebody has asthma. Okay. So, could it be exacerbated by diving? Yeah. Cold nebulized hypertonic saline and exercise could promote asthma. So, possible. Could it precipitate a diving disorder? Yeah. Well, if you have asthma, you could have gas trapping, which could then cause pulmonary barotrauma. If this happens, could it compromise performance in the water? Well, yeah, if you have an asthma attack underwater, you could reduce exercise capacity and be in trouble. So when you see somebody with asthma, it can mean a lot of different things. Like if they had asthma when they were a kid that they outgrew, that's probably okay. If they're unstable, like they're like, I have to take my rescue inhaler every day, that they shouldn't do. The equivocal ones are, well, I use Ventolin a few times a year for cold, pollen, cats, etc. In that case, what we might consider doing is having pulmonary function testing, maybe do it pre and post exercise, or give them some saline in the lab and see how they do with it. And if they can exercise and handle some hypertonic saline in the PFT lab, then they're probably okay. Sometimes you might put them on preventive treatment, like some steroids or something, put them on that for a while, retest them if there's a problem, and then again, you got to have a risk-benefit discussion. There was in the Philippines, so that was a scorpion fish sitting when we were doing a muck dive. Those are venomous, by the way. You don't want to touch them. Another one that's really common, probably overdiagnosed now, is ADHD. Exacerbated by diving? Well, probably not, but the medications that people take for stimulants may lower the seizure threshold, which could cause a seizure if they're on, say, amphetamines or something for it. AKA Adderall. Could it precipitate a diving disorder? Well, inattention and distraction definitely could cause some barotrauma. And compromise performance in the water, well, it may interfere with ability to handle tasks. So, possible. And the other thing is, some people may be off their ADHD medicine for the summer while they're out of school. Well, then you have to look at what their capacity is to handle things. They reduce the risk of the med. So, history of remitted ADHD is probably okay. If they're stable, you might need to have their instructor kind of do a functional evaluation, make sure they're okay. Shouldn't stop medications just to be able to dive, risk-benefit analysis. If there are residual or incompletely treated symptoms, they really shouldn't be done. This is an example of a stonefish. This can be deadly if it stings you. They don't move around and they camouflage, and this is also in the Philippines. So this is where buoyancy control is important, because you don't want to be bumping into this sucker and getting stung by it. The venomous spines are on the dorsum, so if you bump into it, it's a problem, but they're totally non-aggressive. Okay, another one, obstructive sleep apnea. Okay, could it be exacerbated by diving? No. Okay. Can it precipitate a diving disorder? It's like, well, sometimes they have some pulmonary hypertension, which could potentially cause an increased right to left shunt, so possibly. Basically, but the biggest thing is it's likely associated with poor overall fitness, so that could also indicate a risk of cardiac disease, so that one's a positive. So what we might do is we might assess what their real exercise capacity is, do the cardiac workup. If they have normal cardiac function, exercise capacity, and pulmonary arterial pressure, we might allow diving with counseling about, hypothetically increased risk of DCS, benefits of weight loss, and regular exercise every day. That was in Kona, the Mana dive. So it was really cool because we'd set up lights and they feed on the plankton and come right up to you. So I managed to get a picture looking right down its mouth. As we know, they're filter feeders, but for commercial diving, they're extremely scary. because if somebody's diving on an umbilical, if there are manta rays around, they'll abort the dive or they won't do the dive because sometimes the manta can get tangled in the umbilical and they're extremely strong. And there have been cases where like divers have been dragged from saturation depth up to the surface by a manta ray entangled in the umbilical. And it like pulled the bell around and everything. So, so they're very dangerous as far as
Dangly things.
you don't want dangly things, but they're completely non-aggressive. Sometimes they'll actually perform for you. So, diabetes. Okay, nice common condition here. Okay, exacerbated by diving? Precipitated diving disorder? Probably not. The issue is that it can compromise performance in the water. If somebody loses consciousness, they could drown, or if they get hypoglycemic underwater or hypo or severely hyperglycemic, they could have impaired decision making. It used to be the answer was no diving. It still is commercially, with very few exceptions. For recreational diving, though, now Dan has kind of realized that people have done it anyway and been doing it. Generally, you have to be well controlled on a stable regimen, so 3 months on oral agents, 1 year on insulin. Well controlled with your hemoglobin A1C. For those of you who aren't diabetic, it's a measure of diabetic control. Normally less than 5.6. 6.5 is cut off for diabetes. Dan recommends that it be controlled to an A1C of less than 9, which isn't the greatest control. But the other thing, no episodes of hypoglycemia unawareness. So you have to be aware that your blood pressure is getting low. No recent glucose excursions requiring help. No significant secondary complications like heart disease. And we recommend the cardiac workup because you get what we call silent ischemia, which means that you could be having coronary disease without having pain or anything.
What's silent iso?
That's silent ischemia means you might be having heart disease and not have any pain or symptoms from it. So it's more common with diabetes.
So,
So you don't have the classic chest pain, in other words. So Dan now recommends that if you're going to have someone with diabetes dive, that they do 3 pre-dive glucose tests at 60, 30, and 0 minutes prior. Make sure it's about 150 and rising. Delay the dive if it's over 300 or less than 150. Carry oral glucose, dive with somebody who's not diabetic. Ideally, you want to have glucagon, which is a drug that can raise blood sugar, available on the surface, and somebody who knows how to give it. Probably just having glucose around and people who are knowledgeable. Let the dive team know you're diabetic. Dan has this nice infographic that we can give to diabetic divers. Yeah. This is the Pillars of Evolution, formerly the Darwin Arch.
Yeah.
It caught COVID and collapsed. Well, it collapsed during COVID.
yeah, plateau.
Yeah. And I think probably getting to the last one here, or we'll be able to make it the last one. Hypertension, probably one of the most common conditions we see. 3-question analysis. Can it be exacerbated diving? Yeah, as we talked about, it pushes fluid into your bloodstream, so that can potentially raise your blood pressure when you immerse in the water. Can it precipitate a diving disorder? Probably not. Can it compromise performance in the water? Well, yeah, if your blood pressure spikes, you could have CVA, which is a medical term for stroke. So possibly it could compromise your performance, so there's always concerns there. The other thing is, too, that you can have medication effects. For divers, we recommend avoiding beta blockers because they can impair your exercise capacity. ACE inhibitors or ARBs, angiotensinogen receptor blockers, are our preferred choices. The ACE inhibitors are the drugs that end in tril, like lisinopril. Beta blockers like propranolol, those are the ones that end in olol, or a beta blocker. Calcium channel blockers can cause dizziness on standing, so you want to be on it for a while, make sure you're tolerating it well. Those tend to end in dipene, so like nifedipine. And diuretics can cause dehydration, electrolyte shifts, particularly like Lasix. Hydrochlorothiazide is a common one people are on, that's less of a concern.
What is losartan?
Losartan is an ARB. So that works similar, it's a angiotensinogen receptor blocker, so it's similar to an ACE inhibitor. So the sartans are ARBs. You usually don't put the ACE inhibitors or the ARBs together. You use one or the other, and either of them, those are the preferred ones for diving. So losartan is one of the preferred ones.
Oh, that's
Yeah.
good enough.
Yeah.
Can I keep train and train my dog?
Usually uncontrolled hypertension. If you're greater than 140 over 160 to 90 over 100, no diving for you until we get it under control. If you're well controlled, you can dive. Well, again, you're at higher risk of heart disease, so we want to evaluate for that, especially if you're older. Allow several weeks after medication changes. both to evaluate effectiveness and to make sure you're not having any side effects from your regimen, from your medication regimen change before you get diagnosed. This is the Russian destroyer at Cayman Rock. I actually got to dive with the guy who unfortunately has passed away now, but he was the one who applied and sank it for them. And this, you used to be able to actually do a swim through, and you could see the control room, and it was all the controls are in Russian in there. So that made it about time. That brings us to the end of the to the end of the presentation. One common